Luke Figora joined Northwestern as Assistant Vice President for Risk Management and Safety in 2015, moving from the University of Chicago, where he held a similar position. On April 1st of this year, he was promoted to Vice President for Operations, becoming key deputy to the Senior Vice President for Business and Finance. Luke has an MBA from Chicago Booth and a BA from Lake Forest College. We will begin with brief remarks after Luke introduces the other two panelists with brief remarks from each of the panelists. And then I will pose questions to the panel that we have received from faculty members. Now, Luke, take it away.
Thank you. Thanks, Therese. And again, really quick, do appreciate the opportunity to be here today and the invitation. And want to thank Mike and Rich for their time and willing to join me here as well. Both Rich and Mike have been advisors to us this entire pandemic, and we've pulled a lot of their time away from medicine and research, and so appreciate doing that again. They both have really long titles and signature lines, so I'll give you the high points, and you both can feel free to go deeper on it. But Mike Ison is a professor for infectious disease and organ transplantation out of Feinberg, and Mike, I believe, also the director for the Center for Clinical Research as well. And has helped us really heavily with a lot of vaccination planning. And then Rich has been really involved on the pandemic planning with myself since day one. Rich is the Associate Vice President for Research here at Northwestern, Senior Associate Dean for Clinical and Translational Research, and also Professor of Medicine and Infectious Disease. So really just fantastic expertise from both from Mike and Rich. So appreciate you guys both joining us here again today. Therese, we'll be really quick and kind of give a brief update from each one of us. I did pull together just some quick slides on some data points that I thought would be interesting for faculty to see. So this is just, again, some quick update on data and what we've been seeing. So this goes back to January 1st of the year. So encompasses all of winter quarter and spring quarter. And so you can see this is the surveillance testing program that we've been running here at Northwestern. And so the green bars are just the daily tests that we've performed. You can't really see the orange and the red, which red takes into account the positive cases. The red numbers are kind of the 7-day moving average of new cases that we've identified. So you can see kind of for the last 5.5 months here, we've been running a aggregate positivity of about 0.3%. We found about 675 cases over this period of time, and actually pretty consistent. When you look all the way back to January, we saw a little bit of a spike around spring break, but otherwise pretty consistent, kind of week to week over the course of over this period of time. Looking a little bit more recent, which is a great story to tell. So this is the last 4 weeks of data. Again, pretty similar testing volumes that we've been looking at, a little over 10,000 a week. It's dipped off slightly just the last week or two. But you can see, positivity has dropped below 0.1%, and that 7-day moving average of new cases is really low. And obviously, this is a testament to the impact of vaccines playing out in our community. So again, a great story to see here. Just a couple other charts just to show folks. This is a dashboard that we create. So this pulls together all of our what we call case management information and tracks the number of individuals in the community who are currently infected, in isolation status, quarantine status. The gray bar is actually kind of those totally in aggregate that are in kind of a contact tracing process at any given time. And so again, I think the story here, relatively consistent over the course of the quarter. Again, little pockets here and there, but nowhere near the spikes of kind of aggregate activity that we saw at a lot of the peer institutions across the country, both of the Big Ten and kind of our private peers. And then the last kind of set of data here, this shows that same information again over the last 4 weeks. And again, you can see a great story. The numbers have really fallen off a cliff in terms of newly identified cases, those in quarantine or isolation. As of today, we actually have 0 students in on-campus quarantine or isolation housing, which it's actually been that way for a few days now. But the first time we've had that really since we started this whole process back in August. So the numbers are going really, really favorably across campus. Just a couple other pieces from me before I'll ask Rich and Mike to say a couple words. We are, I think, as most people probably know, in the bridge phase of the state's reopening plan. So this was something new. Some call it phase 4.5. But it's something that the state has inserted between the initial phase 4 and kind of the initial phase 5. And so we have followed this kind of public health guidance at the university level. So you can see, again, this is just information straight from the website that we've posted in terms of what capacity is allowed in various settings on campus today. And we will continue to modify this as we move forward. One quick piece I'm sure we'll talk about a little bit in the Q&A section is around masks. Currently, I think hopefully as everyone knows, we do require masks in indoor settings on campus, not in most outdoor settings. And that's been affirmed by the public health agencies that it's required at schools in this kind of bridge phase. So the last slide I just put together briefly is, kind of looking forward. And again, I think we'll touch on some of this in the Q&A section. But we do expect the state to move into phase 5 on June 11th. That's the date they've given us. And all the data looks like we'll hit that target, if not maybe a little bit sooner. Our current expectations, based on what we've heard from the state, is that really does mean kind of a full reopening. So no capacity restrictions, no types of things that we can't do. Unclear today what phase 5 means in terms of masks in kind of healthcare settings and colleges and universities. We'll get more information about that piece of things, I think, but really phase 5 is presented as kind of back to normal, again, with some unique pieces. Couple questions have come in about how we're thinking about testing going forward. We've gotten pretty firm guidance that both for the summer and the fall, the public health agencies actually want us to stop testing individuals who are vaccinated and asymptomatic. So we will likely shift to a testing program that focuses on those who are not vaccinated or who are symptomatic, but obviously keep it available for anyone who wants it. And hopefully everyone saw our notice yesterday about some at-home tests that are available. So we're excited about that. Obviously, again, I think everyone saw the vaccination requirements for students. I'm sure talk a little bit more about that. And the last piece, we're still working through some open questions. We're thinking about symptom tracker and the concept of vaccine passports. Again, waiting on some guidance to emerge on a few of these pieces. I mentioned masking. Rich is going to talk a little bit about vaccines and potentially boosters. So again, still thinking about some open questions, but I think excited about phase 5 and the current environment on campus looks really good. So I did want to turn over briefly to Mike, and who's got some knowledge about what's going on at the NM system and what we're seeing in the hospital side of things.
Great. Thank you, Luke, and thanks for the opportunity to talk with you today. We have had a very interesting past year here at Northwestern Medicine with the shutdown of the city back in March, which really represented a huge peak in volume of COVID cases here at Northwestern. Those came down during the summer and then again rose to even higher levels as we moved past the mid-October point last year. Thankfully, as we moved into the holiday season, our numbers started declining again and have been relatively low. We did have a slight peak in cases starting in the beginning of April, with a decline pretty significantly over the last couple of weeks. Currently, we have had 1 week of consistent reduction in the number of patients admitted to the hospital and in the ICU with COVID-19. Our test positive rate throughout the entire Northwestern Medicine system, including all of our affiliated clinics and hospitals, currently is at 3.2%, pretty close to the nadir earlier this year of 2.1%. We have opened up our clinics and hospitals to allow for much more normal operation. We still have dedicated COVID units that will be continuing for the foreseeable future. Our research operation is moving forward in full steam ahead, basically. Most of the non-COVID research studies are close to back to their normal function, and the COVID studies are moving along with lower numbers as we have ongoing. So hopefully that provides you a reasonable update on where we are within NM.
Great, thanks, Mike. And then, and Rich, I know we'll talk probably a little bit more about some questions that folks have about vaccines, but maybe give a little sense of what we're seeing in terms of the variants and some of the vaccine questions and research that you've got going on.
Sure, happy to do it, Luke. There's been much in the news about what the CDC calls variants of concern. And I want to just point out that That's the second top priority. The top priority, they label variants of high consequence. We don't have any variants in that category today. Variants of high consequence would be of concern because they're going to escape from coverage of the current vaccines. We were concerned about the ones on this slide and a few others because we had to check and be sure. But I think at this point, there are multiple studies pointing to the fact that the UK variant is fully covered by the current vaccines. And the others on this slide, as well as the one that is now prominent in India, are also very well covered. Slightly less well covered in the lab, but in clinical studies, the vaccines protect against serious illness from any of these. And over the weekend, there was a very encouraging report that both the Pfizer vaccine and the AstraZeneca vaccine, when studied in Britain, appeared to fully protect against the India variant, which is now circulating more widely in Britain. And the next slide. There we go. This colorful slide is from colleagues of Mike and I who work at Feinberg. These are awesome junior faculty, Egan Ozer, Ramon Lorenzo Redondo, and Judd Hultquist. And they've been sequencing nasal swabs from hospital patients at NMH. And it's a little hard to see everything here, but the blue off on the right indicates the uptick of the UK variant in hospitalized patients here. I have to add that all of the patients in the hospital have not received vaccine. I think there's maybe been one or two minor illnesses that we've seen in vaccinated people, but nothing serious. The little brown curve that's coming up on the far right of the slide there, yep, that's right. That represents the P1 variant that was first seen in Brazil. And as you can see, that's really starting to come up. It's getting up to about 10%. But again, everything here, there's some that are variants of interest, which is a lower level, some that are variants of concern, none that are variants of high consequence, because everything here so far is covered by the vaccines.
Thanks, Rich. Maybe before we turn it back to Therese, just any commentary that you might offer on the vaccine efficacy and what we're learning about kind of contracting and shedding the virus, post-vaccination.
Yeah, and the data have come out a lot over the past few weeks, and they're continuing to come out. And Mike can probably chip in on this one as well. It looks like when vaccinated people do get infected, what we call breakthrough infections, it can happen, but it's about the same rate as we saw in the clinical trials. It's low. It's 5% or so of those who are vaccinated. The important thing that we're learning is that when nasal swabs are taken from those people who have infection, there's very little virus there. So the chance for being able to spread it to someone else, we think, is minuscule or non-existent. There have been no reports yet of spread of virus from a vaccinated person. Did I get that right, Mike?
Yeah, I think the other thing that has come out is that the majority of breakthrough infections are relatively mild, rarely resulting in hospitalization or death. So that's a huge benefit, that I think people focus on the prevention of infection, but if they do get infected, it's unlikely they're going to get very sick or die from the infection. And that's true even though we've heard the reports of immunocompromised patients not getting the same amount of antibody formation. They still receive significant benefit in reduction in severity of illness if they get sick after the vaccine.
Oh, and can I take the liberty of addressing another issue that's been in the news, which is the durability of vaccines and whether we're going to need boosters? this is a very active area for research. And as Mike said, antibody levels do decline both after natural infection and also after vaccines. The level after vaccines is much higher than after natural infection, particularly if there was a mild natural infection, it's like 100-fold higher. But it does decline. But there was a report published in Nature yesterday that was covered in the New York Times today that shows that you can still find memory B cells, and that means your body's poised to remake those antibodies within hours to a day. It doesn't have to wait a long time to generate the antibodies as it does the first time it sees the virus. So that's very encouraging, and it says that though, as long as those cells are around, we may be protected. And that article estimated that it could be multiple years of protection. And that's even shorter than what we expect the lasting effects of the other arm of the immune system, the T cells, to be. T cell immunity is induced by vaccines against viruses, and that's very long lasting, many, many years. So we just have to see, but so far, I'm optimistic that as long as we can stay ahead of the variants and prevent evolution of a variant that is resistant to the vaccines, we may be good.
So Therese, hopefully that was a helpful overview, both on kind of where we've been, where we're kind of going, as well as the science update, and happy to answer any questions that you may have.
Yes, very helpful. Thank you very much. I do have the questions that were sent in advance. I do want to, you've answered some of them and maybe all of them, but I want to read them anyway, and so that you can kind of confirm what I heard just now. So the first one is kind of a series of questions. It appears that why has Northwestern adopted a COVID safety plan for the fall that appears to have fewer safety protections than peer universities? Many elite universities have mandated vaccination for all employees, as well as students. They are retaining indoor mask mandates and are keeping large lecture courses online. Many are also retaining remote work arrangements for vulnerable employees or those with vulnerable children, whereas NU appears to have eliminated these as of July 20th. How will the university keep immunocompromised faculty and those with medically fragile children not yet eligible for vaccination safe? Will it require masking indoors for all? Will a vaccine passport system be implemented?
So I can take at least a piece of those, and then again, I think Rich and Mike may have addressed a piece of it with kind of the vaccine shedding or the virus shedding piece. But I think at a high level, we're still making some final decisions for the fall. And I think all along we've really said that our goal is to be in lockstep with recommendations from public health, and I think we'll continue to follow that. We've got great relationships with CDPH, IDPH, and Evanston Health and Human Services here. So we haven't made a final decision about kind of indoor mask mandates. Again, right now, the state has confirmed that colleges and universities are included in their definition of schools, and that right now masks are still required indoors in school settings. So we're following that guidance until the state changes it otherwise. And again, similarly, the question about mandated vaccines for employees, no final decision has been made on that at this point. Again, I think the more urgent issue was the student piece, just given the sheer timing of when students leave for the spring, summer, giving them enough time to get vaccinated before they have to register for classes. But we continue to think through that piece of things. There are pros and cons on it, and challenges, and we're obviously seeing this play out across the country. I don't know, Rich or Mike, anything more you'd say about that? Okay, the risk on the immunocompromised things, kind of again, post-vaccination, family and the individual.
Yeah, so as someone who takes care of immunocompromised patients all day, I know that that's something that these patients are very worried about. We've gotten data to suggest that they have reduced responses compared to otherwise healthy patients. I think that in the end, if you feel more comfortable wearing a mask, even if the mandate isn't there, there's no reason why you can't wear a mask. I will still be wearing a mask for a while indoor settings until we get more of the public vaccinated. I think that the key thing is if the majority of people around you are vaccinated and you wear a mask and avoid people that are sick and focus on hand hygiene for yourself, that's the best approach to prevent infection in yourself. I would also talk to your provider because most immunocompromised patients will receive some benefit from vaccine, and that is something that is recommended for nearly all patients. There are some that are receiving some specific therapies where it needs to be timed appropriately around those therapies.
Yeah, if I could just add to that, Mike, I don't know that we have enough data for recommendations now, but I anticipate as we get more data on immunocompromised people and how they respond to vaccines, maybe there's going to be a different regimen for them. Maybe they need a third shot in order to get a good protective response. So I think we just have to stay tuned for that. But as you say, in the meantime, if you are immunocompromised or you're worried about a family member who is, wear a mask. I mean, it's up to you. And I think it's very important that we not stigmatize mask wearing. If people want to do it, they can and should. And I'm with Mike. I definitely will be wearing it in all transit and hospital settings. And, the other question about mandating for employees, mandating vaccines for employees, I think, as Luke said, we sort of had to give the students advance warning to get it done. But the FDA is going to review certainly the Pfizer vaccine and probably soon after the Moderna vaccine for full approval. That means they get 6 months worth of safety data. So after that review, if the vaccines get full approval, I think then we're on firmer ground in saying to everybody, look, they're safe. And we really want everybody to be vaccinated for the sake of our community.
Excellent, thank you. And again, I think you've talked about the next question a little bit already, but I think it's just everyone's gonna feel better if we kind of reconfirm. Next question, if a member of a faculty member's own family is not vaccinated, either they're too young to be vaccinated or for some other reason, and the vaccinated faculty member is concerned about spreading the virus, are they still required to return to campus? Should they be concerned about spreading the virus if they themselves are vaccinated?
So again, I can talk about the high level kind of university's return plan. I think folks have seen the announcement that came out a week or so ago about kind of a return to campus policy. The plan for the fall is to have students back and again, hopefully more like normal. And we know there's a strong urge for in-person activity from the students and return to the classrooms and things like that. So I think we are expecting to have most faculty and staff kind of back on campus in the fall. Rich and Mike, again, I think you alluded to the shedding question, but maybe just to follow back up on that piece.
Yeah, I mean, there's still studies going on that are going to confirm this, but every piece of data that's come in so far shows minimal virus is shed. And, you can sort of see it in some of the curves and some of the data that Luke showed. Once you get above a certain level of vaccination in the community, cases disappear. And, this has been the situation in Israel and Britain. They're a little bit ahead of us in terms of vaccine, and, they're doing great.
And the only thing else that I was going to do as a shout out is that I think we should be proud of Northwestern, and with a lot of help with Luke, we have a study that's ongoing enrolling Northwestern students to really help answer this question. The patients just got their second dose from the initial cohort of patients. So it's going to be a couple of months before we get the readout from that study. But I think we at Northwestern are contributing to the science to help us answer these challenging questions.
Excellent. Thank you so much. I know you spoke earlier about booster vaccinations. Is there a concern that those of us who are vaccinated will be less protected during the period just before we receive the booster?
Well, I'll try to handle that. That's a good question. And I don't know that we have a firm answer yet. But one thing that we do know is that there's a range of responses. So some people are going to have, right after the vaccine, really high, great responses. And some people are not so great. But what we've seen so far is that the decline in those responses is similar. So, and you can't really get tested for that. There are no quantitative good assays for surrogates of protection that are on the market. There's research assays, but they're generally not available. So I have to say it's possible that some percentage of people may have low levels of protection before they get a booster. But the latest paper that came out last week estimated that all you need for protection is about 20% of the maximum level. So again, everything is sounding pretty encouraging.
I think the other thing too is everyone's focused on the antibodies, but there's also those cellular responses, and those should persist so that even if you get a breakthrough infection and you've been previously vaccinated, you should persist with the protection against severe disease, hospitalization, and death.
Thank you very much. So it appears that the question is, why did Northwestern Medicine seem to have so much less vaccine availability than, say, Loyola University, who was able to offer vaccination to folks even outside their network as early as February? And many of us weren't contacted by Northwestern Medicine until April, when we were already vaccinated.
So I could comment at a high level. Again, Mike, feel free to chime in, obviously, if you like. We've worked exceedingly closely with Northwestern Medicine throughout the entire pandemic, and they've been really supportive of Northwestern University. I don't think it was a case that they had less vaccine. I think they were actually one of the largest vaccine administrators in the city of Chicago, in the state, frankly. The local departments of public health ultimately drive how a provider can administer their vaccine, and NM was operating within that framework. And so initially that was vaccinating their own, a segment of their own staff. And again, remembering that Northwestern Medicine and Northwestern University are separate organizations. So the first kind of tranche was really on their employees, the kind of congregate setting, their own patients. And so it was really about who they were allowed to distribute the vaccine to versus them not having as much vaccine. But I don't know, Mike, did I cover that appropriately?
Yeah. So I was heavily involved, particularly when we moved into the patient rollout of the vaccine. And I know it was frustrating for everyone that people wanted the vaccine and we just didn't have enough. And part of the challenge is even though we had a fair allotment of vaccines, we did not have enough to meet the demand for our both staff and patient population initially. When we first started opening up for patients 65 and older, for example, we had nearly 200,000 people to be vaccinated and only had about 10,000 doses per week. So as you can imagine, to kind of meet the demand, it took some time and took kind of prioritizing individuals based on risk of exposure to COVID-19 in their work in the healthcare setting, as well as highest risk for severe disease.
Yeah, if I could just add, I think initially the big push was to get all the healthcare workers in the NM system vaccinated so that people who needed to access healthcare services felt protected and safe, because people just weren't taking care of themselves and not coming in when they should. And then when they rolled it out, as Mike said, to patients, I think they did it the right way in prioritizing, starting with the oldest patients and the most underserved zip codes. And as the vaccine became available, they would go down to younger ages and less underserved areas. But, you know, in conclusion, right now we got plenty of vaccines. There's no reason to hesitate. You can get it.
Thank you so much. What are the plans if some foreign students are unable to return to campus?
So, Therese, I'm not the perfect person to answer this. I can say that the provost office is working on this exact question. We do suspect that there may be a smaller segment of international students that may have trouble accessing campus. Working on kind of contingency plans for that. We don't think it'll be nearly as high as what we saw, obviously, this past year with the travel restrictions, but there may be still some. And so, again, that's something being worked through right now. I don't think all the answers are kind of there quite yet.
Okay, thank you. I just have one more, it's not actually a question, a comment that was sent in advance, and then we're going to go to some questions that are in the Q&A that have been collecting there. So one faculty member wanted to say what a great job you've done with testing. They shared a personal anecdote. After traveling over a weekend, this person came down with a cold, but you never know these days, even if you're vaccinated, whether or not it's COVID. After class, I went across the street from the office to the testing center. I got a test and had the negative result in about 15 minutes. Having the rapid test, as well as the one that takes several days for results, has been great. No appointment for the test, no cost to the faculty, no limit on how often one can be tested. Great job. Thanks, Luke.
Appreciate that comment. And we know the situation's evolved greatly since August, and it was amazing. Back in August, we had trouble finding tests, and Mike and Rich were involved in that. I mean, it's a different world now, and we've also said is we're not going to sit on our hands. We've tried to evolve our testing program as the landscape changes around us. So appreciate that comment.
Great. All right, so now I'm turning to the questions that came in chat. Some of them overlap with what, overlap with one another. There are many questions in the chat about requiring faculty and staff to be vaccinated. Do you expect Northwestern will require vaccination of faculty and staff at some point?
So it's an active discussion right now. I would say, and I made this comment in a different setting recently. I think it would make life a lot easier from a planning perspective, right? If that requirement was there, and if you knew everyone in your community was vaccinated. So from a big picture public health perspective, you've got that. There are challenges, right? There are kind of legal concerns, employment concerns. There are some segment of the population that we know have already reached out and said, the university better not require me to get a vaccine or better not ask me to get a vaccine. And there again, there's complications with taking in employee medical data and retaliation and all this kind of stuff. So it's a complicated topic. We actually got a data set just yesterday of the AAU school, about 36 AAU schools. I think it was 11% or 12% are requiring. Over 60% have made the decision not to require. So I would say we haven't made that final decision yet, Therese. We are actively kind of working through it. I'll say, and again, I'm very interested actually in this, any feedback Rich or Mike have on this. When you just look at it, I mean, we don't know for sure, but when you look at all the different data sets we have in terms of response to our vaccination, kind of clinic invites, the self-disclosure, the people we've provided vaccines to directly, and then the data from the city of Evanston. I would not be surprised if the Northwestern faculty and staff vaccination rates are upwards of 80% or 85% already. And I think that, again, the case data is playing out that our community is highly vaccinated. And we've seen, again, very little, essentially no transmission amongst faculty and staff on campus the entire year. So I do just wonder, to capture that last 5% of people or 3% of people, how much ultimate public health benefit that's going to have for the offsetting complications. But again, I think these are all the things we're thinking through. And again, I don't know, Mike or Rich, if you have any thoughts on that.
Well, I'll jump in. Yeah, I agree completely. We don't know what that magic number is, what percentage, but it's somewhere above 70 and maybe it's 70. So at some point, I think we just have to say people who want to get vaccinated can get vaccinated. And if you don't want to, well, you may or may not be protecting yourself, but we're not going to be concerned that there's going to be a lot of spread from a small number who are isolated and hopefully surrounded by people who are protected, so there's not these ongoing chains of transmission.
Thank you. Let's move to again a question about individuals, faculty members who are immune compromised people. Will those immune compromised faculty members teaching in person in the fall, well, will they be allowed to choose to teach remotely?
So again, I think that's, I don't feel as comfortable, to be honest. Therese kind of answering that question only because I think that's a kind of an academic decision and a little bit beyond my skis. But I know that kind of the question of accommodations is under discussion right now, both for students and for faculty and staff. And I think will be addressed in that context. Thank
you. Could we have some discussion of anticipated social distancing requirements once we get to phase 5? More specifically, what will the requirements be for students in classrooms, particularly in classes with large enrollments?
That is a fantastic question, and one that I've been trying to get an answer to from public health for the last 4 months. So yeah, my current assumption is that in phase 5, there are kind of no classroom density restrictions. So just in terms of 60%, 70%, whatever it may be of kind of traditional occupancy, folks saw that the CDC put out kind of 3-foot radius guidance on K through 12 population. Now, again, that's a population that's typically not vaccinated, or at the time wasn't planned to be vaccinated. We have not gotten any guidance yet on the college age, university age population. So, my best guess is the guidance that comes out ultimately from CDC and IDPH says you can have students back in the classroom if the majority of them are vaccinated. Again, whether masks play into that or not, we're not quite sure what they're going to say yet. But my current guess is that we are not going to have kind of hard social distancing expectations in classroom pushed on us from the public health agencies. Again, Rich and Mike, not sure if you're hearing anything more on this subject, but that's what we've been able to get from IDPH so far.
Yeah, I think you're right. I know a few months ago there was a study in Massachusetts, not in higher education settings, but in elementary and high schools. And there was really no difference between 3-foot and 6-foot distancing. That's what allowed the CDC to sort of loosen the guidelines. And if everybody's vaccinated, that's an even better situation than when that study happened and nobody was vaccinated.
Therese, I might just add just really quickly, and again, we've said this, but I think it bears repeating. We do every positive case that we've identified at the university this past year, we do a kind of root cause on it, right? Full contact tracing case management process. We've identified 0 cases that appear to result from any kind of classroom-based transmission. And again, that was in a unvaccinated population at the time. And so we do really feel that the classroom settings are safe, the lab-based settings are safe, the work setting is safe. The transmission we saw, as you would probably expect, actually, even the residence halls were really safe. We didn't see spread in the residence halls. It was the off-campus kind of social type gatherings is where we saw it.
I think we have time for just one more question before we move to the next part of the agenda this evening. Is there any data on fully vaccinated individuals getting long COVID, i.e. illness that does not result in hospitalization or death, but does cause extended issues?
Go ahead, Mike.
I haven't seen any specific data on that. I would expect that it would have a positive impact, but we don't have the data. I think the vaccine itself, since it isn't causing COVID-19, should in and of itself not cause that, and it hasn't been seen in the studies that have been done so far. There have been some anecdotes of people that had long COVID having improvement in symptoms with the vaccine, and again, is an area that needs to be studied. Northwestern Medicine, like a lot of institutions, have set up a clinic focused on long COVID, and this will hopefully address some of these problems and whether vaccines are helpful in the management of these patients.
Yeah, I just emphasize what Mike said. There's no trace of virus in the vaccines. It's just a tiny one component that your body can recognize. And, we think that people who get long COVID after natural infection are having problems either because the virus is persisting or because their immune system got so disturbed and deranged by the virus infection and is still overreacting to it. And, neither of those things happen after vaccines.
That's great news. Thank you so much. Thank you very much, Luke, Rich, and Mike. Really appreciate your willingness to share your time with us this afternoon and share your expertise. It's been a great conversation. Thank you so very much.
You're welcome.